It's time for another warm-up review. Let's get going. First question here, which amino acids are found in nuclear localization signals? The mnemonic here is going to be PAL, P-A-L, for proline, arginine, and lysine. All right, next one. What molecule targets proteins in the Golgi apparatus for lysosomes? And that's going to be mannose 6-phosphate. Next, which embryonic structure is derived from the hypoblast and serves as a secondary energy source? And the answer is going to be the endodermal yolk sac. That brings us to the end of the warm-up. Let's get to that lecture now.
One of the things that's very high yield about neurology is being able to look at a patient's neurodeficits and then localize the lesion to a particular area of the brain, especially in the brain stem, where there are a whole bunch of different tracts and nuclei that come together so that one little lesion can cause a bunch of different deficits. And one of the important clues in those brainstem lesions is the cranial nerve deficits that you find. So in this video and the next one, we're going to be talking about the cranial nerves. And then we'll look at the brainstem and start figuring out what these lesions look like. Now, I'm sure you've already memorized the cranial nerve names and numbers. I'm not going to review that. But I do want to review the anatomy of where these cranial nerves are located as they come off the brainstem. You definitely need to be able to identify these on a gross image. So take a look at the brainstem drawings in your study guide, and I want you to pause the video and label as many of these as you can, and then we'll go over them together. Don't spend a lot of time, but do as much as you can in a minute or so. So first we have the dorsal view, or the posterior view. A is the pineal body. B is the superior colliculus. And what did we say a lesion to the superior colliculus will cause? Paralysis of upward gaze. C is the optic tract, which becomes cranial nerve 2 on the ventral side. But note that there are just a handful of cranial nerves that emerge from the posterior or dorsal brainstem. D is the inferior colliculus, which receives a lot of auditory information, and then it relays that information to the primary auditory cortex. E is the trochlear nerve, or cranial nerve 4. That's another one that emerges dorsally. Then F is the trigeminal nerve, or cranial nerve 5, just kind of peeking out from the other side of the pons. G is the vestibular cochlear nerve, or cranial nerve 8, which is another ventral one. And so is H, the facial nerve, cranial nerve 7. Then peeking out from the front of the medulla, we can see I, which is the glossopharyngeal nerve, cranial nerve 9. Then J is the hypoglossal nerve, cranial nerve 12. K is the vagus nerve, cranial nerve 10. And L is the spinal accessory nerve, cranial nerve 11. Then looking at the ventral view, which is probably higher yield, M is the olfactory tract, which is going to go on to become cranial nerve 1. N is the optic chiasm. And O is the pituitary stalk. Now, the pituitary has been cut on this drawing, but remember that the pituitary sits right underneath the optic chiasm, because if there's a pituitary tumor, it might compress the chiasm and cause bitemporal hemianopsia. P is the mammillary bodies. Now, what did we say a lesion there causes? Wernicke-Korsakoff syndrome. And what was the vitamin deficiency associated with that? Thiamine deficiency. Q is the oculomotor nerve, cranial nerve 3. R is the trochlear nerve, cranial nerve 4, which is coming around from the back of the pons. S is the trigeminal nerve, cranial nerve 5. T is the abducens nerve, cranial nerve 6. U is the facial nerve, cranial nerve 7. V is the vestibulocochlear nerve again, cranial nerve 8. W is the glossopharyngeal nerve, cranial nerve 9. X is the hypoglossal nerve, cranial nerve 12, which comes off between the medullary pyramids and the olives up front. Y is the vagus nerve, cranial nerve 10, which tends to be a little bit bigger than these other cranial nerves coming off the medulla. So if you get disoriented, the big one is most likely the vagus. And then Z is the accessory nerve, or the spinal accessory nerve, cranial nerve 11, which actually comes up from the spinal cord. Before we get into the functions of the cranial nerves, we also need to review the location of the cranial nerve nuclei. So cranial nerve nucleus is a collection of neuron cell bodies of the neurons that form that cranial nerve. Now, some of these nuclei are fairly condensed, while others stretch out longitudinally and extend for several centimeters. And a lesion of one of these nuclei will cause specific neurological deficits, just like if you severed the cranial nerve peripherally. So, knowing the location of these nuclei will help you localize brainstem lesions and brainstem strokes that we're going to be seeing later on. So, there are 4 cranial nerve nuclei in the pons, and 4 below the pons, and then 4 cranial nerves originate from above the pons. And to remember which ones are in the pons, I want you to think about a cheerleader with pom-poms, starting a cheer by saying 5, 6, 7, 8. So cranial nerve nuclei 5, 6, 7, and 8 are in the pons. Cranial nerve nuclei 9, 10, 11, and 12 are located below the pons, mainly in the medulla, except for the spinal accessory nerve nucleus, which is found in the spinal cord. And then cranial nerves 1, 2, 3, and 4 originate above the pons. So the nuclei for cranial nerve 3 and 4 are found in the midbrain, and cranial nerve 1 and 2 originate from the forebrain. Now we're going to look at each cranial nerve individually, starting with cranial nerve 1. So for each nerve, you should know the nerve's function, how you test it, what happens when there's a lesion so that the nerve isn't functioning properly, and where the cranial nerve exits the skull. But you don't need to worry about knowing the fiber types, like whether each nerve contains general somatic efferents or general visceral afferents and that sort of thing. So cranial nerve 1, or the olfactory nerve, is what provides the sense of smell. So you can test it by having the patient smell something like cinnamon or coffee or orange peels, something that produces a recognizable odor. Now you don't want to use an irritating smell like alcohol or menthol. Those will actually stimulate the trigeminal nerve. A lesion of the olfactory nerve will cause loss of sense of smell, obviously. Cranial nerve 1 exits the skull at the cribriform plate, sending branches into the nasal cavity. So if there's a fracture of the cribriform plate, that might sever those nerve branches and result in anosmia, or loss of sense of smell. The next several cranial nerves deal with the eyes. So cranial nerve 2 is the optic nerve, which of course provides vision, or the sense of sight. It exits the skull through the optic canal, and you can test the optic nerve by testing visual acuity using a Snellen eye chart, by testing the pupillary reflexes, which we're going to discuss at the end of this video, and also by testing visual fields, which we'll discuss right now. To understand visual field defects, we need to review how visual information is gathered by the retina and then transmitted to the brain via the optic nerves. We divide the visual field for each side into a nasal or medial side and a temporal or lateral side. And likewise, each retina is divided into a nasal side and a temporal side. Now, when we look out at the world, the lens projects a mirror image onto the retina, so that objects on the temporal side of the visual field are actually perceived on the nasal side of the retina, and objects on the nasal side of the visual field are perceived by the temporal side of the retina. So far, so good. Then, as we follow the visual signal down the optic nerve toward the brain, you eventually reach the optic chiasm. Now, chiasma is a Greek word for crossing, like an X or the letter chi. So at the optic chiasm, there's a crossing over of visual information. So that information from the temporal visual field of the right eye and the nasal visual field of the left eye is carried by the left optic tract. So objects on your right are perceived by the left side of your brain. And information from the temporal visual field of the left eye and the nasal visual field of the right eye is carried by the right optic tract to the right side of the brain. Then, once you've got that down, we're ready to think through some visual field defects. There are 5 basic visual field defects that are high yield for step 1 and level 1. Now, the first one's pretty easy. What happens if you lesion the optic nerve on one side? Well, that's going to leave you with no vision in that affected eye. The next one, what if you lesion the middle of the optic chiasm? Well, this might occur with a pituitary mass that grows big enough to compress the optic chiasm, because the pituitary sits just inferior to the optic chiasm. So if you compress or otherwise lesion the optic chiasm, you're going to disrupt those crossing fibers from the nasal retina, which carry information from the temporal visual fields. So a lesion of the optic chiasm will result in loss of temporal vision in both eyes, and we call this bitemporal hemianopsia, kind of like tunnel vision. Now, what if we lesion an optic tract? Remember, the optic tracts carry information not from the contralateral eye, but from the contralateral visual field. So a lesion of the right optic tract will cause loss of vision in the left visual field in both eyes. We call this homonymous hemianopsia. In this case, left homonymous hemianopsia. Now, what if you just lost vision in the center of the visual field in both eyes? Well, this occurs with a lesion of the macula found in the retina, such as from macular degeneration. And then if you had homonymous hemianopsia with macular sparing, so you lose one side of the visual field, but the central visual field remains intact, this can occur with a posterior cerebral artery infarction. So the macula is so important to our vision that the macular tracts receive collateral circulation from the middle cerebral artery. That's why the macula is spared with a PCA infarction. So make sure you know those 5 visual field defects. Now let's move on to cranial nerve 3, which is the oculomotor nerve. As the name suggests, it provides motor innervation to most of the extraocular muscles. We'll review which muscles in just a moment. But you also need to remember that cranial nerve 3 provides motor innervation to the levator palpebrae muscle, which raises the eyelid. So a cranial nerve 3 lesion will cause some drooping of the eyelid, which we call ptosis. And cranial nerve 3 sends parasympathetic fibers to the ciliary muscles and the pupillary sphincter. So cranial nerve 3 lesions can impair accommodation and can result in a dilated pupil. Now cranial nerve 4 is the trochlear nerve, which innervates the superior oblique muscle, another one of the extraocular muscles. And cranial nerve 6 is the abducens nerve, which innervates the lateral rectus muscle, which abducts the eye. The abducens abducts. It's not difficult. Now all three of these, cranial nerve 3, 4, and 6, exit the skull together through the superior orbital fissure, which makes sense since they're all basically going to the same place. So let's look at how the extraocular muscles work together to move the eyes, and how the cranial nerve palsies will cause the eyes to deviate in certain directions. The extraocular muscles are the lateral rectus, the medial rectus, the superior rectus, the inferior rectus, the superior oblique, and the inferior oblique. So you need to know what cranial nerve innervates each of these 6 muscles and in what direction each muscle moves the eye. I'm sure you're familiar with the mnemonic LR6SO4 or LR sulfate, which reminds you that the lateral rectus muscle is innervated by cranial nerve 6, and the superior oblique is innervated by cranial nerve 4, and then all the other muscles are innervated by cranial nerve 3. Now, for the movements, let's start with the straightforward ones. The lateral rectus abducts the eye. It moves the pupil laterally. The medial rectus adducts the eye. It moves the pupil medially, plain and simple. Then the superior rectus is not quite as simple, but it's not bad. The superior rectus elevates or raises the eye when the eye is abducted. And the inferior rectus depresses or lowers the eye, again, when the eye is abducted. Now let's explain that. Here we're looking down on the eyes and the extraocular muscles. Now the eyes and the orbits are oriented at about a 45-degree angle from each other. And the superior and inferior rectus muscles are lined up roughly along that axis. So when you're looking straight ahead, which ophthalmologists call primary position, when you're looking straight ahead, the eyeball is already rotated off of that natural angle. Now when the eye is abducted so that it lines up with the plane of the superior and inferior rectus muscles, those muscles produce pure elevation or depression. That's why I said the superior rectus elevates the eye when it's abducted, and the inferior rectus depresses the eye when it's abducted. So we test those muscles not by having the patient look straight up, but by having the patient look out, then up, or out, then down. So you have the patient follow your finger laterally to test the lateral rectus, then up to test the superior rectus, and then down to test the inferior rectus. Then the last 2 extraocular muscles are the superior and inferior oblique muscles, which get even trickier because the inferior oblique starts anteriorly and wraps underneath the eye and attaches toward the back. And then the superior oblique starts posterior, but it passes through the trochlea, which acts like a pulley, and then it attaches toward the back. So all the movements are kind of backward. So you can remember that the obliques do the opposite. O for oblique and O for opposite. The superior oblique moves the eye down, and the inferior oblique moves the eye up. But notice that the 2 oblique muscles both attach to the eye in the same plane. And that plane's about 80 degrees from the plane of the superior and inferior rectus muscles, so it's almost perpendicular. This means that when the eye is adducted so that it lines up with the plane of the oblique muscles, the obliques are isolated. So the superior oblique depresses the eye when it's adducted, and the inferior oblique elevates the eye when it's adducted. So again, to test the obliques, you have the patient follow your finger medially, which is going to test the medial rectus, and then up to test the inferior oblique, and then down to test the superior oblique. So your finger's making an H to test all 6 cardinal directions of gaze. And notice that you may see these directions drawn in 2 different ways. You can draw it so it represents the direction that each muscle makes the eye move, or you can draw it to show what directions you have the patient look to test the extraocular muscles. So now let's talk about what it looks like when there's a lesion of one of these 3 cranial nerves. Let's start by drawing in the basic direction that each muscle points the eye. Again, the lateral and medial rectus are easy, lateral and medial. Superior and inferior rectus are both oriented so that they tend to adduct the eye, so the superior rectus moves the eye up and medial, and the inferior rectus moves the eye down and medial. And the obliques are opposite, so they tend to abduct the eye, so the superior oblique is down and out, and the inferior oblique is up and out. Now that we've got those directions down, it's pretty easy to figure out what an individual cranial nerve lesion is going to do. If there's a cranial nerve 6 lesion, the eye is going to deviate medially, and the patient will be able to abduct the eye. That's pretty easy. And cranial nerve 6 lesions are the most common cranial nerve palsies affecting the eye because cranial nerve 6 has so far to travel. If there's a cranial nerve 4 lesion, which is pretty rare, the eye is going to drift upward, especially when the patient's looking away from the side of the lesion, when the eye is adducted, because the superior oblique depresses the eye when adducted. And these patients tend to tilt the head away from the lesion to compensate. And then a cranial nerve 3 lesion will paralyze all these muscles. So the eye is going to deviate down and out. Just remember, down and out with a cranial nerve 3 palsy. But don't forget that cranial nerve 3 also sends parasympathetic fibers to the pupillary sphincter and to the eyelid. So with a cranial nerve 3 lesion, not only do we see a down and out eye, but you also see pupil dilation and ptosis. So let's talk about the pupillary light reflex. First, remember that fight or flight sympathetic stimulation causes mydriasis, or pupillary dilation, in order to let in as much light as possible while you're fighting off a predator or running away from a predator. And the rest and digest parasympathetic stimulation causes miosis, or pupillary constriction. But you also know that the pupils dilate and constrict in response to the amount of ambient light. That's why we test the pupillary light reflex. This tests both the optic nerve and the oculomotor nerve, because both have to be intact for the pupils to function normally. So let's look at how it works. So here we're looking down on the head from above again. So what happens when you shine your pen light in the patient's left eye to test the pupillary reflex? The afferent signal is carried from the eye toward the brain by the optic nerve to the optic chiasm, where some of the fibers cross over, and then down both of the optic tracts. Now, some of these neurons synapse in the lateral geniculate nucleus, which is part of the thalamus that relays visual information to the primary visual cortex. But that's not important right now. What is important is that some of these optic tract neurons are bypassing the lateral geniculate nucleus and projecting to the pretectal nucleus. So this is an entirely different route than regular vision. Now the pretectal nuclei project to the Edinger-Westphal nuclei bilaterally. The Edinger-Westphal nuclei are located in the midbrain, and they contribute the parasympathetic neurons to cranial nerve 3. So when the pretectal nuclei get a signal that there's increased light entering the eye, they stimulate the Edinger-Westphal nucleus, which sends a parasympathetic signal back up the oculomotor nerves to the ciliary ganglia. From there, the signal goes to the pupillary constrictor muscles of the irises, and the pupils constrict. So with all that crossing and bilateral signaling, light shining in either eye will cause pupillary constriction in both eyes. Now, there are two main ways you can mess up this pupillary reflex. One way would be to somehow impair the afferent signal, blocking the incoming message that there's light shining in the eye. We call that an afferent pupillary defect. The other way is to impair the efferent signal, the parasympathetic signal that actually triggers the pupillary constriction, and that's called an efferent pupillary defect. So, say there's damage to the left optic nerve. Is that an efferent defect or an afferent defect? That's an afferent defect. So if there's a lesion of that left optic nerve and you shine the light in the left eye, nothing happens. Neither pupil constricts. The pretectal nuclei and the Edinger-Westphal nuclei have no clue that you're actually shining light in that eye. And then when you swing your light over to the right eye, which is the good eye, you see the right pupil constrict. And the left pupil constricts also, because the oculomotor nerve's parasympathetic signal is perfectly intact. So if you shine your light in one eye and neither pupil constricts, that's called an afferent pupillary defect. Or sometimes it's called a Marcus gun pupil. But say instead of an optic nerve lesion, you have a left oculomotor nerve lesion. So when you shine your light in the left eye, the signal goes down to the pretectal nuclei and the Edinger-Westphal nuclei, but that damaged cranial nerve 3 can't send the parasympathetic motor signals to the left eye. But the right oculomotor nerve is just fine. So here, the right pupil does constrict when you shine light in the left eye. And then when you swing your light over to the right eye, again, the right pupil constricts normally, but the left pupil still won't constrict. So that's an efferent pupillary defect. One pupil won't constrict when the light shines in either eye. So it's important to swing that light back and forth from one eye to the other and watch one eye at a time to make sure they constrict normally regardless of where the light is. That's called the swinging flashlight test. Now, the parasympathetic fibers in cranial nerve 3 are located on the peripheral outer part of the nerve, while the motor innervation to the extraocular muscles is carried in the center of the nerve. So it may help you to remember P for parasympathetic and peripheral, and M for motor and middle. But this anatomic structure means that a mass lesion that compresses the oculomotor nerve from the outside is more likely to affect what? The pupils or the extraocular muscles? The pupils. A mass lesion will compress the parasympathetic fibers going to the pupils long before it compresses the central nerve fibers to the extraocular muscles. But since the fibers to the extraocular muscles are located deep within the nerve, they're more susceptible to ischemic damage. So diabetics, who are at high risk of microvascular ischemia, are more vulnerable to pupil-sparing third nerve palsies, where the eyes deviate down and out, but the pupillary light reflex remains intact. So that's cranial nerves 1, 2, 3, 4, and 6. We skipped cranial nerve 5, but we're going to cover that one in the next video, along with cranial nerves 7 through 12. But for right now, let's take a look at the end of session quiz. First question, which cranial nerve nuclei are located in each of the following locations? So first is the medulla. That's cranial nerves 9, 10, and 12. Cranial nerve 11 is the spinal accessory nerve, so it originates in the spinal cord. Which nuclei are located in the pons? Remember, it's cranial nerves 5, 6, 7, 8. And in the midbrain, you have cranial nerves 3 and 4. Next, where is the pathology located in each of the following scenarios? So right anopsia is a lesion in the right optic nerve. Then the next bullet had a little typo. It should say bitemporal hemianopsia, and that's a lesion of the optic chiasm. And then right homonymous hemianopsia is the left optic tract. And the last question. When light is shown in a patient's right eye, his right pupil fails to constrict, but his left pupil constricts normally. And when light is shown in the left eye, the left pupil constricts, but the right pupil does not. So where's the pathology most likely located? Well, this is a defect of the right ocular motor nerve. This is an efferent defect. We know that the light is getting in normally because when you shine the light in the right eye, the left pupil constricts. The problem here is that no matter where you shine the light, the right pupil won't constrict. So again, this is a problem with the right ocular motor nerve. That's it for now. We're going to cover the rest of the cranial nerves in the next video. I'll see you then.